joining from so many places from all over the world. So
yes,
thank you for joining us. Good afternoon, this afternoon, this morning, this evening, this night, whichever one. Please take one, and we can move ahead from there. Okay. I would like to read the profile of Professor Tarek Ali shortly, and we can just go ahead from there.
So,
and sometimes I lost.
can I share my screen?
Yes, please. Yes, please.
Is it now okay? I don't know start
Yes.
now.
Yes, go on, go on. I'm just trying to. It's been open and closed so many times.
Now everything's clear. My slides are clear.
Yes, beautiful, beautiful. Okay, Professor Tarek.
My slides are clear.
Yes, everything is clear. Do you mind if I just say 1 minute about your profile before you start?
Yes, actually, thank you. First of all, first of all, I would like to thank the UCG for inviting me to share my experience and knowledge with the attendees and the colleagues in this respectful conference and medical gathering. And actually, I'm a senior physician, but also I have qualifications from the Faculty of Law and the Philosophical Sciences and Jurisprudence at Al-Azhar University. That's why you will find a lot of talk about the relation between medicine and law and the effects of philosophy of medicine and science on medical practice and in the clinical field. That's why I will first start to talk about this, and then to proceed to the main topic of the conference or the presentation in the conference about the priority of patient safety in clinical decision making. This is the my topic is patient safety in clinical decision. The disclosure is that I have no actual or potential conflict of interest in relation to this presentation. The presentation has no commercial background, and I have no financial conflicts of interest to declare. And the presentation will be discussing the science and the art of patient safety. So the outline of my presentation will be the nature of medicine and the medical profession, the clinical management rules, philosophy of science and philosophy of medicine, and its relation to the medical profession and the issues of patient care and cure, the healthcare management system, definition of safety of patients in the healthcare process, the hazards of unsafe clinical practices, ethical and legal aspects of unsafe practice, and then summary and conclusion. Everything is clear, Dr. Sharifa? Do you hear me?
Yes, everything is clear.
Okay.
Everything is clear.
So let's talk about the science and art. We all know that as medicine, there's a difference. First of all, we have to know that there's a difference between medicine as a discipline and the medical profession as an industry. There's a difference between both, so as not to confuse terms together or concepts together, because everything has a definition, at least for us as philosophers, that everything has a definition. And this definition might be a linguistic definition and a definition related to the discipline or to the profession. Medicine is a science of uncertainty and an art of probability. So there's a consensus that medicine as a discipline is a science and an art. It is a science in the essence of being a knowledge, and it is a science because we get it from the study of medical sciences, both the basic medical sciences and the clinical sciences. And it is an art. Art is the medical practice. So the science, which is half of medicine, is the knowledge. And then the art is the practice, which gives us or which makes the physician gradually gaining clinical experiences. So this is a difference between science and art. The medical art of practice is a mixture actually of experience, wisdom, and common sense. It is not just experience, it is wisdom and common sense. And we have not to mix between the three. The importance of art in clinical practice, the medical art of clinical practice makes the difference between clinicians. That's the classification of clinicians, senior versus junior, bad clinician versus poor, and versus good clinicians. This is the classification of clinicians. The clinical approach to patient management and the clinical decision making actually there is a lot of dilemma in clinical practice about this. Is it evidence-based? That's clinical guidelines, which are published every year by the different medical authorities worldwide in the East and the West, the evidence-based clinical guidelines. Or is it knowledge-based, or is it wisdom-based? That's art-based, or is it mixture of the three? Actually, in the wise physician or surgeon or medical practitioner should approach his patient by the three. That's using the three. Evidence-based medicine, knowledge-based, which is the basis which he has got from his medical school, and the wisdom-based, which needs time. And this is the most difficult issue in the clinical practice. And the wisdom-based actually is the one which differentiates physician from physician as a clinical decider or as a clinical judge. Because actually, or in reality, the doctor is a judge, but a medical judge. He judges and gives a decision. That's why he is a clinical decision maker, or he is a judge giving decision about his patient or his case. So, or it's a mixture of the three. I mentioned that it should be a mixture of the three. Which one is the most important? It differs from case to case and from situation to a situation. But of course, here the wisdom and the art of practice is important. Wisdom and art. And I will focus in my presentation about the importance of the art of medicine and the importance of using medical wisdom in patient management and in clinical approach. The role of clinical logic here is very important to speak about this, that the role of clinical logic and what we call the basic understanding of the philosophy of medicine and its original concepts in the philosophy of science. We all know that philosophy teach you how to think, understand, and then conclude. So the good doctor or the good physician or a good medical practitioner should be in reality a good thinker, because a good philosopher is a good thinker. He should or she should understand the philosophy of medicine and its relation to the philosophy of science and its relation to the general philosophy. That's why we have to understand the basic concepts of the philosophy of medicine. In my opinion, it is very important for every physician that he or she should understand the philosophy of medicine and medical practice. But for sorrow that the philosophy of medicine is not a subject to be taught or studied in the medical schools worldwide. And maybe it is implemented in higher postgraduate courses or postgraduate curricula that the physician or the medical practitioner should understand the philosophy of science and should understand the philosophy of medicine, because medicine, as I mentioned, is a science. It is part of the science. It is a discipline, and it is a science. It's related to science, especially biology, chemistry, and physics, because inside the human body, there is biology, there is chemistry, there is chemical reactions, there is biochemistry, and there is physics, heart moving and sounds and movements of the stomach, and this is physics. So he should understand the philosophy of science and the philosophy of medicine. For example, in science, we all know that the science teach us that everything has an explanation. Everything has an explanation. That's why in the domain of the philosophy of science, the study of what we call the nature of explanation. What is the nature of explanation? For example, during the pandemic of COVID-19, for example, I will speak about the example from the reality of our life, from real life. For example, in the COVID-19 era, what is the explanation of this virus? How did it originate, and then how did it spread? And can you give us an explanation? To give us an explanation, to give me an explanation, means the scientific basis of why it causes, for example, the COVID-19 occurs has two gastrointestinal symptoms in the prodrome, or why in some cases it causes illness and in other cases it doesn't. And give me an explanation why this vaccine, which has been developed early, did not take enough time to be tested, because we don't know the complete nature and the complete science of this biological agent, which we call it COVID-19. So how can you tell me that this vaccine, I had produced it, and you don't have enough information about this biological agent? So this means that here we will enter into the issue of true science and pseudoscience. And the true science and demarcation between true science and pseudoscience is one, or what we call bad science or false science, is what we call is part of the philosophy of science, the true versus the pseudoscience. Because the true science always, as we say, seeks falsification, and the pseudoscience seeks confirmations on the other hand. So this is the part of the philosophy of science also, which is applied in the philosophy of medicine, that the science, because medicine depends on science, it depends on evidence. I mentioned that in the clinical management, or in the clinical approach, we depend on what we call evidence-based. And when we say evidence-based, this means that there is science. There is science because there is evidence. There is a proof that this disease, that this biological agent caused these manifestations, systemic features and pulmonary or respiratory features, that this vaccine is related to this biological agent, and it will be effective against not all, but this strain, which we said that it is the one responsible for the human problems at the beginning of the episode or the pandemic, for example. So here, this is the issue of what we call the nature, nature of explanation. Everything has an explanation. When a physician meets a case, he should understand, he should try to understand what is the explanation of, for example, the patient now has fever, which is not responding to any medications. I can't find a cause for this fever. What's the explanation of this fever? Here, this means that the physician thinks by the philosophy of science to find an explanation. And also what we call the reality of scientific constructs, which is related to medical practice, and the demarcation between true science and false science in clinical medicine. And then comes what we call the role of values in science, the role of values in science, and the role of values in medical practice, that everything has a value. Even the unknown thing has a value. And here comes the science of what we call the axiology, or the philosophical study of values in science and medicine. And this is a topic by itself, axiology in science and medicine. The values, how to study the values, and what's the importance of values in clinical medicine. Another concept is what we call the inference to the best explanation. And the inference actually is one of the important concepts, and it has a significant role in clinical medicine, because simply what is an inference? Inference by definition is a conclusion reached to based on evidence and reasoning. So it is a conclusion. When we reach to a conclusion that this vaccine is effective, when we reach to a conclusion that this virus is the one responsible for the human problems and the human symptomatology, this is an inference. So the conclusion, and this conclusion should be based on evidence. What's your evidence? What's your proof? And reasoning, adequate reasoning. And using reasoning is what we call logic. That we are using logic, al-mantiq al-ikliniki, the clinical logic. Is the doctor logical in his decision making or not. So this is another concept. So another concept is the inference, which is a conclusion.
No, I think there's I mean, there might be some connection problem with Prof. Tarek Ali. So we just wait and see how.
Logic, المنطق الإقناعي.
Yeah, we just lost you a bit. That's fine. Welcome back.
Now it's okay?
Yes, yeah, continue. Thank you.
Then we come to what we call I will shift to another issue. I mentioned that the medicine is a discipline, the philosophy is a discipline, and actually the two branches meet together here where the wisdom and the science meet. Here comes the field of medicine. As we say that medicine is a medium or a focus in which the problems of wisdom and science intersect or meet together. This is to confirm that wisdom plays a role in medicine and science. You hear me?
Yeah, we can see you now. Thank you. Welcome.
Oh, thank you so much. Everything's okay. Now I can share my presentation, I think.
Yes, connection problem. Yes, you can.
Yeah, there is connection problem.
Yeah, I can see that. That's the technology world.
Now, okay, really. Now it's my slides are clear. My slides are clear. Hello? Hello?
Yes, doctor, your slides are clear.
I'm here.
I don't. Yeah, everything. You hear me and you see my presentation?
Yes.
Absolutely, yes.
Okay. So let me continue. If you hear me, because I'm not sure that my voice is already clear to everybody, and my slides are clear. And my picture is clear. Okay.
Yes, actually, it's clear. We would like to ask you to enlarge your slides, doctor.
Now is it okay?
Yeah, it's fine.
Fine.
Yeah, it's fine. Go ahead, doctor.
So I was speaking about. Okay, so I was speaking about the importance when it was interrupted, my presentation, sorry for that, about the clinical approach depends on being evidence-based. The doctor should be evidence-based and should be using the clinical guidelines, should be also knowledge-based and wisdom-based, and we use mixture of the three together in order to reach to the proper clinical decision and to approach the patient in a clinically wise way, to be evidence-based, to be knowledge-based, to be wisdom-based. And I was explaining that talking about the issue of that wisdom, being wisdom-based, this is the art of medicine. And this is where where we need it in what we call now the precision medicine, which is a modern concept in clinical medicine now, the precision medicine or the personalized medicine or the individualization of treatment or individualized medicine, that we should implement the details rather than the general picture of the case, and rather than using the general outlines, because evidence-based medicine puts general principles and general outlines for all the patients. But we should know that sometimes to apply this on individual cases, here we need to have details about the case, because every patient and every situation is different. And here to individualize treatment or to personalize treatment or to apply precision medicine, we have to implement the wisdom-based approach. So the wisdom-based approach now plays a role in the precision medicine, which is a modern concept in clinical practice. And it's not only enough to have the evidence-based medicine or the clinical guidelines, which might be useful mainly for the junior practitioners, but the seniors and the experts use more their wisdom and their experience in management of each individual case. That's why I said that we should not indulge and impose on the doctors that they just use the clinical guidelines and stopping using their expert mind or mental abilities in the clinical decision making or the art of medicine, which is half of the medical profession and half of the medical practice. My voice clear? Hello?
Hey,
Hello?
I'm here.
Yes,
We're here.
doctor.
Doctor, I can hear you.
Because I'm afraid that I'm interrupted.
No, don't worry. I can hear you. I mute myself because, because there's children watching around the house.
Okay. And I have a phobia now from this internet and the network. So this is very important. So this is very important to observe in clinical management. And the next slide is that we should know that the role of clinical logic, what we call clinical logic, and the clinical logic is very important. The doctor or the physician or the nurse, I mean the medical or the paramedical staff or anyone working in the healthcare management process should have what we call clinical logic. And actually, I will not say in some cases, in many cases, I don't see that the healthcarers use what we call the clinical logic in the clinical practice. And to use the logic means that we should have adequate reasoning in reaching our decision. This is the use of reasoning. And I mentioned this before my presentation was interrupted when I was talking about the philosophy of science and philosophy of medicine, and I mentioned the concept of inference and the concept of pseudoscience and the demarcation of pseudoscience versus true science in clinical medicine. And now I'm talking about and I also mentioned how the clinician should be logical. And to be logical, I mentioned that he uses his mental abilities or her mental abilities to reach to the proper decision based on clear data and based on the normal sequence of events which can lead him or her to the proper decision according to scientific and clear medical knowledge and medical scientific data. This is how to be logical, not to be out or to shift out of the way of logic in a clinical practice. And this is part of the application of philosophy on medical practice or on clinical practice. The medical staff should understand and implement logic in their clinical practice and decision making, basic understanding of the philosophy of medicine and its relation to philosophy of science. And I mentioned this before my presentation was interrupted. I will not talk too much about this issue again. In order to proceed to our main topic, which is priority of patient safety in healthcare management. And then we come to the issue of reality of sound medical practice. Here we should remember and understand that we are treating, this is very important basic facts in clinical medicine. We are treating a patient, not a solitary system. We are not just treating cardiovascular or an endocrine system in the body or a thyroid or pituitary or a liver problem or kidney problem. We should understand that, or the clinician should understand that he is managing a patient. We should pay attention to the rest of the systems. Even if the main problem is in the liver, we should understand when we are treating that there is heart, which might be endangered, there is kidney, there is liver, there is central nervous system, there is bone marrow. And we should put this together when we are diagnosing or when we are deciding about treatment, which medication or which procedure or which treatment option will we give to this patient, whether medication or surgery or radiation or anything, that we are treating a patient, not just a system. And that human character is not just a body. This is another important thing. We are not just treating a physique. We are treating a mind, we are treating a soul. The human character is a soul, mind, and physique. And we know the issue of interaction between the mind and the physique, the big topic of what we call somatization or somatoform disorders, the effect of mind on the body, and vice versa, the effect of body on the mind if the patient has a physical problem. So this mutual relationship between the mind and the body are important to be considered by the clinician when he is dealing with his patient or his case. So it's not just a body. We are treating a disease. Another important issue is that we should understand, not just know. I said before that understand is deeper than to know, and understanding will lead you to the proper conclusion and the proper clinical decision. If you will not understand, you will never reach to the proper clinical decision. You might know, or you think that you know, but you don't understand properly the real clinical problem or the real problem with this human being. So we are treating a disease, not symptoms, not just symptoms. We are treating a disease. If the patient presenting with headache, you have to look for what's the cause of the headache. You will not just give medication to relieve the head pain. No, we should understand. It might be something simple. It might be stress headache, or an anxiety headache, or tension headache, or it might be related to intracranial problem like a brain tumor, or it might be related to an inflammatory state inside like meningitis or encephalitis, or it might be related to other issues, vasculitic problems of the brain. So we should reach to the underlying pathology or to the underlying problem, not just the symptoms. We are treating a disease. That's why the clinical approach should be what we call disease-oriented approach, not symptom-oriented, not just symptom-oriented approach. And this is very important. We should understand the basics of the disease also process. We should understand the pathobiology of the disorder in each individual case. For example, when we are treating a diabetic patient, we should understand what is the cause of diabetes. What is the cause? Diabetes is not just hyperglycemia. Diabetes is a collection or a constellation of metabolic and vascular disorders inside the body. That's why diabetes is a cardiovascular metabolic disease. We should understand what is the pathobiology of diabetes in this particular case. If we understand the pathobiology of diabetes in this case, we can treat it properly. This is what we call pathobiology-based treatment, not symptom-based treatment. We are not just trying to lower the blood sugar. No, we should not. The skilled physician should know, or diabetologist should understand that should try to understand why he is having hyperglycemia. What's the problem? Is the problem related to deficient insulin, or the problem is related to insulin resistance, or the problem is related to both, or the problem is related to the liver producing, there is increased hepatic glucose output, or the problem is related to the incretins of the gut, as a new theory, or the problem is related to the kidney causing retention of blood glucose. So where is what we call the pathogenesis or the pathobiology of the diabetic syndrome? And you can apply this to any disease. If you have a hypertensive patient, what is the pathobiology of hypertension in this? So that I will decide which will be the correct medication. Is it a RAS inhibitor, or is it a beta blocker, or is it a diuretic, or is it a mixture of these together? Because this patient hypertension is plasma volume dependent, or is it due to sympathetic overactivity where we can use beta blockers, or is it related to RAS system hyperactivation? And in this case, we can use the RAS blockers in treatment. So the physician should understand the roots of the disease. This is what we call the root of the disease, the pathobiology of the disease. If the physician will not understand or try to understand the pathobiology of the disease in this particular case, again, I repeat, particular case, because I said again that every individual and every situation in medicine is different. You are treating individual cases. You cannot sometimes apply the general rules on every case blindly. You should work your mind and make your mind to conclude what is the specific problems within this specific case. What is the pathobiology which characterize this case? What is the genotype of this case in genetic disorders and the cancer? What is the clinical phenotype of this case? So trying to understand the roots, trying to understand the genotype, trying to understand the phenotype, clinical phenotype are important to be able to decide and tailor your treatment and give your clinical decision or clinical judgment properly. And this is the important also in the WISE or clinical medicine or application of philosophy of medicine. And number two, after the pathobiology, is to understand what is the natural biologic history. What is the natural history of this? What is the natural history of this problem? This is important also to understand in order to know that every disease in every stage has its imagination and has its way of management. This is what we call the natural history of the disease. Diabetes, for example, is a progressive disease. So at this stage, he didn't need insulin. But later on in the natural history, because gradually there is what we call glucotoxicity and destruction of the pancreas, there will be exhaustion of insulin and the patient might need insulin. And now at this phase, after 10 years, 15 years, the patient might shift to insulin or insulin analog therapy or injectable therapy in order to put his metabolic state under control. This is the natural biologic history of the disease. And so your policy of approach at now will be different from your policy of approach when you treated him or her 5 years or 5 months or whatever time before. That is its internal reality. The doctor should try to understand not just the appearance of the patient, the appearance of the disease. The doctor, the skilled doctor or physician should understand what is behind the appearance, what is the root of the symptoms and signs, what is the pathobiology, what is the pathophysiology. He should look at the internal, not just external. The doctor should look more deeply, not be superficial. This is very important. Again, I say the doctor should look deeply rather than superficially. The doctor should look internally rather than externally. The doctor should look what is beyond the appearances. And when the doctor behave like this, he is applying the rules of philosophy on that. What is the rules of philosophy is, as Immanuel Kant said, that the metaphysics, what is behind the sensible world? The things which we see, the things which we hear, there is something deeper than it. There is something behind it. This is what we call metaphysics. Also, the doctor should understand the metaphysics of the disease. I call it the metaphysics of the disease. The disease is not just symptoms. No, you have to go deeply and understand. And in order to reach the reality of the disease, you have to think well, think and understand. Again, I repeat, think and understand. If the doctor in a hurry in practice, and this is one of the problems, if he is or she is in a hurry, under stressful environment, has too much patience, he will not be or she will not be able to think clearly and coherently, and she will not be able to decide, and she will not be safe to the patient. Here comes the mistakes. She will do medical mistakes, or the practitioner will do medical mistakes. Medical mistakes, which is part of, or which is an important center of our talk today, safety of the patients. So if you don't know how to think and how to focus and how to concentrate and how to understand, and there is lack of knowledge, lack of attention, lack of thinking well, lack of integrity of the doctor, there will be mistakes and there will be unsafe medical practice. This is very important. You hear me? Hello?
Yes, we are.
Okay, so we are treating a disease, not symptoms I mentioned, and we should understand the basics of this. Next, the treatment and the clinical decision should be pathobiologically based. I mentioned this rather than symptom-based. Clinical approach to the case and problem solving should be disease-oriented rather than symptom-oriented. And we should be active rather than reactive. And this is very important also. Being the doctor or the practitioner, the medical practitioner, whatever he is, GP, specialist or consultant or whatever, professor or whatever, he should understand that so long that we are pathobiology based and not symptom based, so long that we are disease oriented, not symptom oriented, we should act actively. The doctor, the wakeful doctor, has not to wait for the next step or the complication or the progress to happen. He should attack it before it happens. This is what we call active, not just waiting for the problem to happen and then react. This is called reactive. The real physician or the real doctor or the real practitioner, doctor or nurse, same also applies to the paramedics working with the doctors, the nurses. The nurse should be active. She should be vigilant, as we say, vigilant and wakeful, not sleepy, and then expect the problem which might happen. And hello, because I hear some. Rather,
just been unmuted. Thank you.
Now okay.
Yeah.
Now okay.
Yes.
But it's not. I didn't touch anything, so I didn't unmute. I didn't touch anything.
No. It's just that I muted because we know it's online and we are all at home and children are on break. So
but everybody is following me and my voice is clear and my
everything is fine. Everything is clear. It's just that
okay.
we have just about 1 minute more for you.
Because I heard somebody interfering or.
So yes. So we have the next speaker around. So I mean, if you just tidy up another 1 minute, then we can go on.
Now I have how many time now? How long time still left
just
for me?
Just 1 minute more.
Me?
Yeah, I mean it's yes, I think we're 12:40.
No,
go to another speaker should be on 12:40.
Okay. So yeah. Because I think I didn't complete the 50 minutes, I am allowed 50 minutes. I
sent a message through the chat box about 5 minutes ago. So you have 5 minutes, 2 minutes more. So
okay, this is very important. The patients have to go to the safety directly. Now, the priority of the patient safety is important, and its relevance to good and wise medical clinical decisions also is very important. And here, we say that safety of patients and its relation to wisdom and experience of practice is very important. If the doctor or the medical practitioner or the paramedics don't act wisely and in time and use the art of medicine, this will cause mistakes or medical errors, and we will have an unsafe environment or unsafe practice. The more the physician is experienced and the more he acts wisely using the art of medicine, the less harmful will be his clinical decisions to the patient in the different phases of patient management and at different times, and to avoid or delay, if cannot avoid, delay at least using hazardous or potentially hazardous medications or procedures, medical, surgical or radiologic or endoscopic or otherwise. Of course, there are many ways to measure patient safety, and this is an issue by itself. Using optimum clinical knowledge and WHO guidelines. The WHO had put guidelines and data to assure patient safety and to assure a good quality of medical services given to the patient. Understand the legal implications also is important. What are the legal implications of the wrong clinical decisions and the legal implications of being unsafe in clinical practice during diagnosis or treatment of each individual case, and I mentioned this. There are legal issues and there are ethical issues. And by the way, the ethical issues are different from the legal issues, and the ethical issues may sometimes be more important than the legal, even if this is not punishable by the legal authorities when the doctor or the paramedics has done any medical mistakes and the complaint raised against him or her. The role of the patient in clinical decision-making, we should respect the role of the patient. The patient should be active, not just passive. And here what we call the concept of active versus passive role of the patient in clinical decision-making and the choice of medication or a diagnostic or therapeutic procedure, and his consent is important, and his acceptance is important. And here, in order that the patient should be active, we should give him education. He cannot be active without being educated or given information and even training, and then we can ask his opinion. If he is not educated about the procedure, about the medication, about the insulin, about the surgery, or about the nature of his disease, he cannot participate actively with the physician or the doctor in making the decision. Same like, do you agree to take the vaccine or not? For example, in our issue here in the pandemic, this is his opinion, but he should be educated about the nature of COVID-19 and the nature of this vaccine or material given to him or her. Human and social aspects of medical practice should predominate in our profession and should precede other considerations like business issues and economic issues which corrupt the medical profession and which might actually corrupt taking a proper decision and cause mistakes rather than and deteriorating the quality of service and deteriorating the safe practice rather than improving the care and the quality of healthcare process. The priority of safety of patient, the quality of service is very important. Assuring patient safety and providing optimum good quality of healthcare service to our patients is central and pivotal issues in the healthcare management, and without them, the healthcare process is disordered and deranged or deficient, because the doctors are working in a stressful environment and working in a hurry and too much patients, so there is lack of attention, lack of concentration, and they are fatigued acutely or chronically, so this affects their mental abilities because they are human beings, and the human beings do mistakes, and as we say, to err is human. So what about physicians? If we put them in unsuitable conditions and ask them to give good practice and to give good care and to give cure, they cannot. This is unrealistic, and they will fall into mistakes and arise the medical legal issues which we talked about it. So the patient safety scope is the burden of harm and scope of unsafe practices includes many things: medication errors, diagnostic errors, perioperative safety issues, unsafe injection and parenteral practices, radiation errors, common diagnostic and therapeutic, infections, and also thrombotic accidents are very common in clinical practice in hospitals and other facilities. The ICU physical and psychological safety is important also. These are very important to understand. Safety of patients is a priority, as I mentioned, and WHO had initiatives for this to date, and its global role in assuring patient safety in clinical practice worldwide is important. Patient safety tips in hospitals and other healthcare facilities should be considered and are tailored by the hospitals individually. I mean that each hospital has its program and has its policy to assure patient safety. But there are general rules of patient safety, which I mentioned them, which should be respected by any medical facility or even by every individual doctor if he is working freelance. I mentioned it to err is human, and to expect perfection and adequate patient safety is sometimes unreal and illogic in human life on earth. Under pressures of stress, busyness, and lack of knowledge, and more importantly, poor understanding of the health carers, that he doesn't understand well the nature of his patient and the disease and the problem of his case, he will not reach to the clinical decision, and he or she will be unsafe in his clinical approach. We know that the doctors should be safe in practice, professional in approach, and kind in attitude. These are the three requirements of any health carer: safe, professional, and kind. So to keep safe, I think, is the most important issue. If you cannot give your proper care to the patient or to be beneficial to him or her, at least don't hurt him or her. If you don't know, say, I don't know the doctor. If the doctor doesn't understand, say, I don't understand, I have to refer the case to a senior colleague to give the decision better than me. This is honesty, and the honesty is the first chapter in the book of wisdom. We should act as medical practitioners honestly with ourselves and our patients. Basic healthcare fundamentals. Safe medical practice is a cornerstone in the healthcare process and is a pivotal issue in clinical practice. Assuming a minimum of patient safety, adequate quality of services is mandatory in all healthcare facilities and a requirement to be understood by all healthcare, especially the medical and paramedics. And in summary, we can say under observation is the art of medicine. Sometimes too, don't touch the patient. Don't give, especially in chronic cases. I mentioned this, that in chronic cases, you have time. You should not be in a hurry. Just put the patient, if nothing is clear, so just put the patient under observation. Time will reveal to you the reality of the medical problem, of the clinical problem. And under observation is art of medicine, as Voltaire said. It is the art of medicine. Just put him under observation. But in the acute or emergency or life-threatening situations is different. The doctor should be more aggressive. But in the cold cases and the chronic cases, the doctor can be more conservative. And so long that you are more conservative, you have time, you can just put the patient under observation. Respect the rule of under observation. Wait and see is another golden rule in clinical observation to be remembered. Also in chronic cases or subacute cases, the physician or surgeon has to be in many cases conservative, especially in chronic or less acute. In other cases, aggressive in his approach in acute or emergency. Doctor's attitude, this is what we call doctor's attitude in clinical practice. Is it conservative or aggressive or both, depending on the situation? Each patient and each situation is different in clinical practice. Consider safety before efficacy. This is very important, to consider safety before efficacy during your clinical practice. Depending on the case, depending on the situation, each case has to be understood separately. Clinical decision-making in your clinical approach and use of mixture of evidence-based plus knowledge-based and wisdom-based, and use science and art in your practice. Remember that medicine and medical profession is an art, not just science. And the art depends on experience and wisdom and common sense. We have knowledge, but we don't have common sense. We should have common sense. We should have understanding. We should have wisdom in practice, not just knowledge. Knowledge is not enough. The certificate proves that you know, but it doesn't prove that you understand. The paper, the certificate which you got in the university or from this medical school is just a paper. It doesn't prove that you understand. To understand is something else. To understand needs life. It needs experience. It needs wisdom given by God. So this is the art of practice of medicine, which differs between physicians. Don't forget the ethical also and the legal aspects of medicine, or what we call the bioethics and the legal code of medicine. Thank you so much. This is Faculty of Medicine, Cairo University. This is its logo. Thank you so much for the audience. Any questions?
Oh, thank you very much. Thank you very much. That is a wealth of knowledge the Prof has impacted on us. And I mean, it's not about asking, to me, it's not about asking the question, it's about applying what he has advised and what he has said we should put in practice to be able to safeguard patient care in terms of patient safety. I'll just ask 1 minute if anybody has got any question or anything.
Yes, I'm ready for any questions or comments. Yeah.
Or comments, really. We know we have a session for question and answer later in the afternoon, but if anybody has got any other questions.
Because, you know, my topic is a very wide topic and complicated, and there is many philosophical complexities and the complications related to medical practice. So if anybody, and I was just opening and triggering minds of people, but it is every point of this the lecture by itself, actually.
Okay, so that is a very interesting talk, really. Anybody that needs to have comments or questions for 1 minute before going to the next speaker? I know the topics are helpful. Maria Jessica said that, and then Hama,
you can just send me also in my email.
Hama
My
is
email
saying
is
thank you, and a lot of comments at the on the comment sections about the talk. Thank you everyone for joining us today. My name is Sherifat Muhammad Kamal. I'm a pharmacist. I'm chairing this occasion from London. Thank you very much, Prof. And